Right, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. It's truly a pleasure to see you all here today. We will have, inshallah, an insightful session of our journal club and clinical audit presentation. My name is Nizar Yaqub, and I am the Research Department Deputy Director, and I will be your moderator for tonight. Tonight we will be diving into two critical areas of healthcare relevant to our context. We will be in the context of our campaign about colorectal cancer. We will have our journal club tonight about colorectal cancer when we will be discussing the paper titled "The Trends Towards the Right Proximal Shift of Colorectal Cancer is Not Observed in Sudanese Patients." This paper will be presented by Dr. Taysir Abu Median and discussed by Dr. Baha Muhammad, and the research gap section will be discussed with Dr. Rimaz. Afterwards, we will be having our clinical audit presentation about the hand hygiene that was conducted at Atbara and the police hospital. So let us start, everybody. I will be sharing my screen now. I hope that you can see my screen. Okay. If you can see my screen, please let me present Dr. Taysir to start the presentation.
Yes, it's clear.
Go ahead, Dr. Taysir. Dr. Taysir, if you hear me, please can you start?
Yes, thank you, Dr. Nizar. Good evening, everyone. My name is Taysir Abu Median, a research officer at SCSD. Today, I will be presenting the study titled "The Trends Toward the Right Proximal Shift of Colorectal Cancer is Not Observed in Sudanese Patients." This study was published in 2016, and it challenges the global narrative of proximal migration of colorectal cancer by examining patterns in Sudan. To provide a clear understanding, I will start by outlining the research question, then move through the key findings, methodology, validity, and clinical relevance of the study, and my colleague Rimaz will continue with the research gap. Next slide. As we all know that colorectal cancer is the fourth most common tumors among men and the second among women. Specifically in Sudan, it ranked as the fifth among all primary tumors. Recent studies note that proximal shift in some regions, which has important implications for screening and detection. Specifically, the right-sided tumors are harder to detect than the left-sided with sigmoidoscopy. So factors like genetic and lifestyle and diet can influence the colorectal cancer pattern. So this study asked the question, does Sudan follow this trend or it has a unique distribution? Regarding the research question, the author aims to determine if Sudan follows the global trend of the right-sided colorectal cancer. Their hypothesis was that colorectal cancer in Sudan would remain left-sided and it will affect younger patients, unlike the high-income countries. Next slide. The study found that the majority of colonic cancer was located in the rectosigmoid area. This is regarding the anatomical distribution, and only 3% of it in the cecum and ascending colon. Regarding the demographic, the mean age was 51 years or less, and there is no difference between males and females in distribution. The most common symptoms were rectal bleeding and altered bowel habits, and all the cases were adenocarcinomas regarding the histopathology. Next slide, please. This table shows the characteristic of the study group and the distribution through the areas of Sudan. Okay. Regarding the methodology, this study was single-center cross-sectional study with sample size of 30 patients. The data were collected from patients attending the main endoscopic centers in Sudan in Omdurman. The data collection were collected from patients in Khartoum state during a specified period of time. While colonoscopy ensured the diagnostic accuracy, the small sample size and single-center design limit the generalizability of the study. Additionally, the difference between the sample size in the text versus table raises concern about data quality, and there is no control for confounders like diet, genetics, and lifestyle. These were the limitations of the study. Regarding the validity, the results are valid for Omdurman but may not reflect the rural Sudan. However, the study does align with other Sudanese studies, and this is add credibility to the study. And the left side predominance pattern of colorectal cancer. In terms of internal validity, biopsy confirmation strengthen the finding. But selection bias and a small sample size weaken it. Regarding the external validity, the study was limited to urban Sudan, and the finding does not align with prior regional studies. About the clinical relevance of this study, the study suggested that Sudan could prioritize the use of sigmoidoscopy because the majority of the cases were left-sided, and the left-sided colorectal cancer most effectively detected with sigmoidoscopy. That would save the resources, and it also calls for urgent attention to younger patients presenting with symptoms with inflammatory bowel syndrome-like symptoms, that they need more detection and screening. And also, it raises attention to tailored approach. The study suggests that tailored approach to prevention, diagnosis, and treatment may be necessary to different populations. There is a future research needed directions to confirm the findings and explore the underlying factors contributing to the observed pattern of colorectal cancer in Sudanese patients.
Thank you very much, Dr. Taysir, for these points. We will now move to the discussion. Dr. Baha Din. Go ahead, Dr. Baha.
Check voice. My voice clear?
Yes, it's clear.
Okay. Hello and good evening, all of you. Thank you very much, Nazar and Taysir. It is me, Bahauddin Abdelaziz, Director of the Research Department and Development at Sudanese Consortium of Surgical Development. I will continue for the discussion related to this paper. Slide, Nazar. Yes, as you are seeing in the screen, global trend vs local colorectal cancer trend in Sudan. In the recent years, multiple global studies have documented a noticeable trend in the anatomical distribution of the colorectal cancer. As we show here, global trend proximal at right side shift in colorectal cancer, especially in elderly. Then showing a shift toward the right side proximal or proximal colon, particularly among older age group. However, in this study, present different pictures. As we observe it here in the local finding, there is 83.3% of cases in rectosigmoid area. That means is still in the left side. Just especially to this study, there is no evidence of right shift in Sudanese patient, and there is many possible reasons related to this discrepancy or this difference may be attributed to the variety of factors. For example, in the developed country, the right shift is often linked to increased life expectancy or lifestyle change, maybe increased in high fat diet, increased in the red meat consumption, and also sedentary behavior. Additionally, the decline rates to the left side tumor in those country may be contributed to the apparent shift. In contrast, in this study, this contributing factor may be less prominent or differ significantly in Sudan, potentially influencing the observed tumor location. Yes, yes, as we see in these pictures, global vs local colorectal cancer trend. In Sudan, we still it is in rectosigmoid area. That means no proximal shift observed, but in the global, there proximal right side shift. Next slide. No, before this, yes, yes. Another key finding in this study is relative young age of affected individual. The mean age, as we see here, it is 51.1 years. This is globally, but in this study, there is less than 50 years uh, by 46.7 percentage. The mean age, as we see here, it is 51.1 years, and nearly half, 46.7 years, were 50 years old or younger. This aligns with the finding from Central Sudan, where 43.8 of colorectal cancer patients were under the age of 50. Uh, Interestingly, there is no gender difference was found in this study with an equal male to female ratio. Also, clinically, the most common presentation were rectal bleeding and a change in bowel habits, reported by 90% and 80% of patients respectively. These findings are consistent with the previous local study in Khartoum and central of Sudan, which found these symptoms to be most frequent reported. Yeah, next. Yes, no, before this, Nizar. Yeah, histopathology and family history. From histological perspective, all patients in this study were diagnosed with adenocarcinoma, echoing the dominant histopathological pattern seen both regionally and globally in Sudan or other in global. Additionally, family history played a role in about 16.7 of cases, either hereditary polyps or direct family history of colorectal cancer. This is very close to the another study reported in Khartoum-based research. It is about 15.6. Yes, next slide. Yeah, the most important point in this discussion, diagnostic challenges and late presentation. One particularly important point to address in this potential is the potential for delay diagnosis due to symptoms overlap with IBS, irritable bowel syndrome, a far more common and benign condition. Uh, in this study, the sample of constipation and increased stool frequency, typically it is irritable bowel syndrome features, were reported in nearly two-thirds and one-third of patients, as we see here. And such overlap may result in misdiagnosis or underestimation of colorectal cancer risk, especially when physician relies solely on clinical history without further investigation. Uh, our recommendation to face these challenges and avoid the late presentation, uh, before this, related to the late stage feature observed, many patients presented with a sign of advanced disease. Nearly one quarter had abdominal masses, as we see here, 23.3, and intestinal obstruction, 20%. Uh, and 1 in 5 presented with intestinal obstruction. These are a worrying indicator of late stage presentation. It highlights the need of clinician to maintain a high index of suspicion when evaluating persistence, the lower DI symptoms. Even simple diagnosis tool like uh, when to face these challenges and avoid late presentation, we can use proctosigmoidoscopy uh, can play a vital role in detecting a more common left side tumor early, potentially improving outcome. Slide. Okay, finish. Thank you.
Thank you very much, Dr. Baha, for this clarification. We will now dive into the last part of our journal club presentation about the research gap by Dr. Rimaz. Please, the stage is yours, Dr. Rimaz.
Okay, thanks, Nadar. Salam alaikum. I'm Rima Saaduddin, a current SCSD fellow, and I will be presenting the research gap section. So, firstly, let us start by discussing the limitations of the current study. The first point is the small sample size, with only 30 patients involved in the study. And this significantly limits the statistical power and generalizability of the finding. The other point, it was a single center study and all patients were recruited from the endoscopy unit at Omdurman Teaching Hospital. So this might not represent the broader Sudanese population. In addition to that, there is a possibility of selection bias because the study only involved those with a provisional diagnosis of colorectal cancer, who were referred specifically to the endoscopy unit at Omdurman Hospital. So other patient groups like asymptomatic patients, misdiagnosed patients, patients who were diagnosed, for example, during surgery, all these patient groups are not included within the study. Also, we have the cross-sectional study design. The design doesn't allow for assessment of changes over time or allow to establish a causal relationship. Next, please. Also, there was limited assessment of risk factors like dietary habits, obesity, alcohol, and smoking, which, if present, could explain variations, for example, in the tumor location. Also, there was lack of longitudinal data. So the study didn't provide data over time, which could help to assess whether the observed patterns are consistent or changing. So this lack of longitudinal data make it difficult to draw a definitive conclusion about the trends in colorectal cancer in the Sudanese patients. Next slide. Okay, so moving on to the literature gap in Sudan. Here in Sudan, we have limited molecular and genetic studies to understand the regional variations in colorectal cancer pathogenesis. We have limited multicenter and population-based data, few studies assessing screening, awareness, and risk factors. And also we lack of national cancer registries with up-to-date colorectal cancer data. To add on this point, the research department within the SCSD have available data about the colorectal cancer, so those who are interested can reach out to them. Okay, so now moving on to the future research suggestions. So let us give the audience a chance if they have any ideas for future research suggestions to share it with us. You can open the mic or type down in the comment section.
Hello, hi. Hello, everyone.
Hi,
Um,
Shane.
Hi, how are you? So I was quite interested with the topic even before, like I was interested in the burden of the colorectal cancer in Sudan. And in fairness, the study was quite disappointing for me because the number of the patients and loads of stuff that's been not mentioned as well in the limitation. So the endoscopist, the availability of the endoscopy service as well in Sudan, and the terminal, the rate of intubation of the terminal alien by the endoscopists themselves, because such type of studies would help really in the allocation of the screening program of the colorectal cancers. And I've been quite I've been like concerned about the number of the colorectal cancer in Sudan and the patients with the colorectal cancer and the management of that cases, because I could see it's a heavy burden. It's an operative disease. So if you had the data, I'm quite interested to go again and see if actually we have only just a rectosigmoid cancers only. Thus, we could give this that if we had a solid base, like evidence base, that the true thing, because even the symptoms of the right colon cancer would be completely different. People were not present with the PR bleed, which is an alarming symptoms. That's why people in Sudan would seek help. Usually with the right side, people will came with anemia, debilitated, and they usually wouldn't have like scope done for them to investigate anemia. So if there is a possibility, and I'm quite 100% interested to go through the data again, multi-centers, including the actual, we'll go through the endoscopy data rather than the presentations to see the finding, and we'll go as well cecal intubation rate, conducting the scopes, and then the finding of the scope, because it could be operative dependent as well. To give us the data, if we had only rectosigmoid, then the screening program would be easy. We could have like a good plan for the screening program rather than doing a full colonoscopy. If we want to implement a screening program at certain age, it wouldn't include colonoscopy, because colonoscopy is a very expensive procedure as well. Need a highly trained doctor, nurses, and bowel preparation of the patient. So if we only had a rectosigmoid, we could get away with just sigmoidoscopy and rectal enema, which is a completely different cost-effective procedure.
Thank you very
Yes,
much.
you are absolutely.
Thank you very much, Dr. Shima, for this interesting points. Yes, you're totally right with this. Yani, looking forward to have more discussion with that maybe. بحيث إنه يكون في أشياء فعلية تحصل more research on this topic. طيب, if you can continue, Rimaz, maybe we will come back to this point later also, Dr. Shima.
Okay. So here are some few ideas about future research. Future researches can be conducted with larger scales, multi-center and longitudinal studies, so as to better understand the trends and the characteristics of colorectal cancer in Sudan. Also to establish a national colorectal cancer registry. Studies can also be done to investigate lifestyle, genetic, dietary, and environmental risk factors. Also, we can do studies to investigate, for example, how age and gender influence the presentation and outcomes of colorectal cancer in Sudanese patients. Also to evaluate the current screening awareness and early detection programs. In addition to that, a lot of researches highlighted the increasing incidence of colorectal cancer in the younger age group, So maybe we could do further researches to explain this observation. And also we can conduct more researches and have data on the molecular and staging of the colorectal cancer. Next, please. Yeah, that's it.
Thank you. Thank you very much, Dr. Rimas, for this nice presentation. Thank you, everyone. Regarding the points mentioned by Dr. Shima, we're having this month, the whole month, for colorectal cancer. So it's part of our colorectal cancer campaign. So we will be having more reviews, maybe, or more researches. Also, we have a dedicated lab for this in our consortium. We have the lab of colorectal surgery. We have a kind of a national registry, data from Khartoum multi-centers. So maybe if you are interested, you can join us, Dr. Shima, for more work in this topic. Thank you. Thank you very much. After robust discussion on this colorectal cancer paper, we will shift our focus into a cornerstone of infection prevention, hand hygiene specifically. We will discuss the clinical audit done by the great team in the Nile River as a part of our first cohort of clinical audit. They made a very good audit about the adherence of WHO 5 moments of hand hygiene protocols among the doctors and surgical department of police hospital in the Nile River state. It will be presented by Dr. Umniyat. I hope you're here, Doctora, and please open your mic if you can join us.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Can you hear me?
Yes, we can hear you. Just give me a moment to share my screen.
Okay.
Sorry, just in the meantime, can I speak for a little bit قبل ما نمشي next topic لو تسمح لي يعني.
Yes, sir. Please go ahead.
أنا حازم، أنا consultant colorectal surgeon. أول شيء thank you all for the hard work. أنا يعني I attended few من السيشنز اللي اتعملت over the past months. وشكرا دكتور شيماء ريماز وبهاء for the presentations. ده نعمل حبة كريتيك على الاستدي ده نتكلم على colorectal cancer شوية وحاجات very important لأنه I felt إنه لازم to highlight it قبل ما to go to the next topic. في أي journal club I think we should talk about حاجات إنه الستدي what type of research what journal it got published فيها. البيبر اللي اتقدمت دي من 2016 which is قريب ال10 سنين which is unfair إنه نحن to consider it in a representative Sudanese population هسي يعني. وhaving 30 cases إنها to generalize Sudanese community in most of the cancers mainly left-sided mainly rectosigmoid. So كده again is unfair. أنا ما أعرف ذاته. To be honest أنا لو كنت الeditor ولا reviewer I wouldn't have published the paper دي لأنه it's more of an audit. يعني أنت عندك 30 عيان وال30 عيان ده sorry أنا دقيقة هفتح الفيديو بتاعي. عندك 30 patients وال30 patients ده اللي أنت you ended up إنه البروكسيمال شيفت بتاع الرايت كولون رايت كولون كانسرز ما شايفينه في السودان شوية كده is unfair. ونحن جينا بيزد على الكلام ده جينا قلنا إنه نحن قمنا نعمل flexible sigmoidoscopy بس للعيانين ديل عشان to save the resources. الايديا بتاعت انه انت بتعمل فول كولونوسكوبي لاي عيان بتاع كانسر is to exclude الميتاكرونس tumors صح؟ عارفين انه في around 10% من الtumors on the left hand side they have associated the إما polyps on the right side which they will turn into cancers ولا عندهم cancers on the right hand side. I think in use it as a generalizability completely wrong so we should refrain من الحاجة دي. ده audit اتعمل في مستشفى درمان في الاندوسكوبي يونت بتاع مستشفى درمان قال لنا عندنا 30 cases. خليك من الستاتستيكال methods اللي اتعملت في البيبر، لكن قال لنا عندك 30 cases mostly كانوا rectosigmoid. ودي ليه؟ لانه اغلب البرزنتيشن زي ما انتوا قلتوا في السودان is late. فالحقيقه لحد ما يجي يفيل، يا اما يفيل الماس، يا اما يبقى obstructed، يا اما يجي البين، حتى بعد ذاك يجيك المستشفى، لانه ما عندنا سكريننج unfortunately. and I think اذا حنبدا بحاجه الريجستري is a great thing. نشوف لنا طريقه نعمل ريجستري، واي ثينك انه دي حاجه مثلا الSCSD المفروض تاخدها برايورتي بالذات في الشهر ده، انه هاو تو تاكلت مع وزاره الصحه ولا مع اي حته، انه اتليست يكون عندنا الريكوردز بتاع الكيسز دي، حتى بعد ذاك وي كان بروسيد فيرز للاناليسيس اللكتريات وكده. ممتاز.
Thank you. Thank you very much, Dr. Hazem. We're very delighted
You're
to.
welcome.
دكتور we have a registry مبدئيا كده اتعملت احنا خلال السنتين اللي فاتت، قدرنا نجمع كنا نقول داتا ست كبيرة شوية، فيها مجموعة من الداتا الكبيرة، يعني لسه محتاج شغل، احنا ما اشتغلنا عليها كتير، يعني ما في حاجة published منها. ف I don't know if you're interested, maybe you can join us برضو في البروجكت ده as a supervisor. This lab.
ممكن ان شاء الله، اكيد اكيد اكيد. anything will be very helpful I think، بالذات في الفترة الجاية دي، لأنه نحن we try to recover lots of things that happened في the past 2 years يعني.
Yes, yes. If you can share us your email, we will be very thankful, Doctor.
Of course إن شاء الله. Just send me أنا في الجروب بتاع الواتساب، just send me privately برسل لك إيميل أحسن من يكون هنا في الميتنج.
Thank you. Okay, thank you everyone. We will now go into our next part of this session about the clinical audit. I will just share my screen now. Can you see my screen?
Not yet. Yeah.
Okay.
ممكن تعمل زوم أكتر؟ Yeah, بس كده. Hello everyone. Mumniat Amir. I'm gonna present Rival Nile team audit, which is adherent to WHO hand hygiene protocols in the surgical department, in the police office, in the police hospital, in the River Nile state in Sudan. Firstly, I want to thank SCSD for giving us this opportunity and to be part of them, of this clinical audit. Can you move there? This is our audit team. Me, Mumniat Amir, Nada Abdullah, and Arwa Ibrahim, and Saad Adam. Next. Firstly, at the start, as you all know, that hand hygiene represents the most important protocol in the management of infections in the healthcare environments. So this is why we choose this topic for its major role in diminishing the transmission of healthcare-associated infections. Next, please. In recognition of the critical importance of this seemingly simple yet highly effective practice, the WHO or the World Health Organizations عملت أو established the 5 moments for hand hygiene سنة 2009 as a globally applicable framework. This strategy provides a clear guidance to healthcare workers on the specific instances during patient's care when hand hygiene is absolutely essential. Next please. طيب الصورة دي بتوضح لي ال 5 moments اللي عملت لها establish WHO. ال first moment اللي هي before touching the patient. ال second moment اللي هي before clean aseptic procedure. ال third moment اللي هي after touching the patient ال fourth moment اللي هي after touching the fluids. The fifth moment which is after touching patient surrounding. Next please. So our aim of this audit was to assess the adherence to hand hygiene protocols within the surgical department. We did it by systematically observing and documenting hand hygiene practices among doctors in the surgical department. Please, next. دي الستاندرز اللي كان عملنا لها establish في البداية قبل ما نجمع الداتا لكل مومنت، اللي هي المومنت الأولى اللي هي before touching the patient كان الستاندر بتاعها 90%. المومنت الثاني اللي هي before clean aseptic procedure اللي هي كان الستاندر بتاعها 95%. المومنت الثالثة اللي هي after body fluid exposure اللي هي كان الستاندر بتاعها 98%. المومنت الرابع اللي هي after touching the patient اللي هي كان الستاندر بتاعها 90%. and moment 5 اللي هي after touching patient surroundings which is الستاندر بتاعها كان 85%. next please. Regarding the methodology, the study was prospective study. The inclusion criteria was the doctors currently working in the surgical department involved in the patient care and surgical procedure. Regarding the exclusion criteria, were non-medical staff or the administrative staff and the doctors not directly in contact with the patients. Regarding the population, إحنا ما كان ركزنا على populations, we focused just on the moments done by doctors. Regarding the sample technique, we use direct observation للprimary data. We observe doctors by using a structured checklist based on the WHO 5 moments. Next, please. Regarding the data collection tool, as I said, we use structured checklist اللي هي based on the WHO 5 moments. Regarding the sample size, due to the indeterminate population size, we just took a cross-sectional approach. We observed at first in the first cycle we observed 80 moments, and we observed in the second cycle 71 moments done by doctors. Next, please. Regarding the time frame of data collection, data collection occurred during two distinct time frame. الفيرست سايكل كانت جمعت الداتا بتاعتها من يوم 12/12 ليوم 24/12/2024. السكند سايكل كانت الداتا بتاعتها اتجمعت من يوم 16/3 ليوم 24/3/2025. next please. Next. As you all see, this chart represents the result of the first cycle. First cycle, regarding the first moment, it was the adherence rate for the first moment was 17.6%, and the adherence rate for the second moment was 67.1%, and the adherence rate for the third moment was 27.3%, and the adherence rate for the fourth moment was 30%. And the adherence rate for the fifth moment, which represents the most adherence rate, was 100%. Next, please. After the data collection of the first cycle and the result of this first cycle, we established recommendations, but unfortunately ما قدرنا نطبق كل recommendations، بس الحمد لله قدرنا نطبق معظمها. اللي هو في البداية we spoke to quality improvement office and we did a practical training sessions to doctors and interns and registrars working in the hospital, and we spoke to them so they can ensure adequate or essential hand hygiene supplies such as soap and water, and to ensure also or improve access to clean water and sanitations. Next, please. دي pictures بتوضح الامبلمنتيشنز اللي احنا عملناها. علقنا بوسترات اللي هو قيم كل مغسلة، وزي ما قلت لكم اتكلمنا مع ال Quality Improvement Office وكانوا فرينا كل السبلايز المحتاجينها. Next please. After 1 week of the establish of our implementations, we collect the data of the second cycle. As you all see in this chart, this is the results of the second cycle. The first moment adherence rate was 85.7%, and the adherence rate for the second moment was 100%, and the adherence rate for the third moment was 91.6%, and the adherence rate for the fourth moment was 100%, and the fifth moment was 100%. Next, please. Regarding the results of the first and the second cycles, regarding moment 1, which is before touching a patient, compliance increased from 32.6% in the first cycle to 85.7% in the second cycle, which show improvement of 53.1%. Regarding the second moment, which is before touching a septic procedure, the compliance increased from 73% in the first cycle to 100% in the second cycle, which show improvement of 27%. Regarding this third moment, which is after touching patient's surroundings, the compliance increased from 70% in the first cycle to 100% in the second cycle, which show an improvement of 30%. The compliance rate for after body fluid exposure increased from 40.6% in the first cycle to 91.6% in the second cycle, which show an improvement of 51%. Next, please. In the second cycle, the targets were met for before aseptic procedures and after touching patient and after touching patient's surrounding moments. In the first cycle, no targets were met except for after touching or after body fluid exposure risk، اللي هو زي ما شفنا في الريزلتس تحت الفيرست سايكل كان already مطبقينها بطريقة كويسة. Also showing a significant improvement in compliance rate for before touching a patient moment, which is 85.7%، لكن لسه ما كانت مثل الكراتيريا للستاندرد بتاعتنا اللي هي كانت 90%. أما ال compliance rate بتاع ال moment of after touching a patient اللي هو increase from 66.6% في first cycle to 100%, which is met our target. Next, please. As a result of overall adherence, في second cycle, the overall adherence was 94.36%, demonstrating a strong level of compliance and closeness to the WHO recommended threshold. أما الفيرست cycle كان الادherence overall adherence بتاعها كان 48.9%, which significantly below the target أصلا. Next, please. Next. Regarding the first and second cycle, we note that in the first cycle 53.7% من الداتا اللي اتجمعت كانت from interns، and في second cycle كانت 83.1% من الداتا اللي اتجمعت كانت من الانترنز. عشان كده when we did action plan we focus on them and we spoke to them specifically and we did the training sessions for them, like repeated training sessions. Next, please. That's all. Thank you all for listening, and I'm happy to answer any question.
Thank you very much, Nihat, for this great presentation. I hope if anyone have any question for the audit team, please write it in the description, often in the chats. For now, I'm wondering if everyone of this team is here. هل موجودين بقية التيم حقين الأوديت؟ I just want to ask you شنو أكبر المشاكل؟ okay, that's good. شنو أكبر المشاكل اللي واجهتكم أثناء عملكم الأوديت ده؟ وشنو الحاجات اللي مشت somehow غلط أو عدلتوها أو لقيتوا فيها شوية صعوبات؟
والله أكتر the most difficult thing was يعني البراكتس. هم أي صح الانترنز كانوا معانا وكانوا مركزين، بس لما يجوا البراكتس بينسوا كده. فإحنا كنا عاملين برضو غير عملنا سيشنز، كان عملنا لهم tracking، اللي هو كان كنت بمشي معاهم، كنت بعمل لهم tracking، بقول لهم يعني ركزوا على المومنت بتاع before touching للبيشن، اللي هي دايما كانت بتتنسي، حتى كان الاتشرنس بتاعها في البداية كان قليل بصورة واضحة شديد. I think كان 27% بس. ف we focus on them, on their training
طب
and their tracking.
التراكنج ده كان كيف بالضبط؟ هل كنتوا عاملين تراكنج شيت مثلا، ولا كان بيرسونالي بتمشوا لأي واحد من الميديكالز الموجودين وتابروتشهم يعني؟
الحاجة الكويسة إنه كان في البوليس هوسبيتال الانترنس ما كان كتار، so we know them and they know، يعني they know me. فالتراكنج كان بصورة واضحة، يعني إنه أول ما يشوفوني يعني بيعملوا تراكنج بصورة كويسة، يعني بيكونوا متدربين وكده.
اوكي طيب that's very good. طيب regarding your sampling، قلتوا في الأول إنه كان عندكم 71 moments. كيف اخترتوا ال 71 moments ديل؟ يعني هل كان في أي نوع من أنواع الراندمايزيشن، ولا كيف اخترتوهم بالضبط؟ هل كانت تعتمد على الشفتات؟ أيوه تفضل.
معلش ما فهمت سؤالك.
أيوه المومنتس اللي كانت في الأول قلتوا كان في زي you observed about 71 moments.
لا، دي السكند سايكل كانت 71، الفيرست سايكل كانت 80.
مم. طيب ال 80 اللي كانت في الأول ديل كيف اخترتوها بالضبط؟
سناب شوت just.
يعني كانت حاجة ورا بعض مثلا، يعني اخترتوا يوم معين وراقبتوا فيه كل الكيسات اللي
No,
دخلت؟
no. Uh, no, we collect the data from different departments, surgical departments. We collect the data from ER and ICU and repair and ward. So the data from different places from in different times.
مهم. Very good. طيب هل في مشاكل واجهتكم مع إدارة المستشفى؟ Did you approach them, the quality officers الموجودين؟ هل دار في نقاش حوالين تطبيق ال WHO تشيك ليست دي من عدمه أو لا؟
معلش الشبكة شوية بتقطع. ايه السؤال التاني معلش؟
عفوا سألت عن ال WHO تشيك ليست، هل دار نقاش فيها مع الإدارة؟ هل ناقشت تطبيقها من عدمه؟ اللي كان في نقاش مع الكواليتي اوفيسرز الموجودين؟
لا لا، هم أصلا they know، يعني حتى كان في بوسترات معلقة لقاها الكواليتي امبروفمنت اوفيس ذاتهم.
مم. هل تواصلتوا مع الكواليتي امبروفمنت اوفيس بخصوص الاوديت بتاعكم؟
أيوة، حتى هم كانوا يعني مراقبيننا وكانوا متوقعين مننا يعني الريبورت الأخير ورسلنا لهم، وحاليا بس هنخطط إنه نعمل لهم برزنتيشن هناك في المستشفى وكده.
اوكي that's very good. تمام. هل في تايمينج معين حصل يعني هل في توقيت معين للبرزنتيشن هتقدموه لهم في وقت محدد؟
آه لسه we still don't know يعني.
تمام. طيب thank you very much. This is the questions for me. If anyone else have any questions for the audit team, please go ahead. Okay. Okay. I
لو
think
ما في زول عاوز يسأل أنا بسأل. طيب يا يسار.
تفضل تفضل.
well done يا أمنيات والتيم كله ما شاء الله، يعني very good audit. طبعا الهاند واشنج audit ده دائما بيكون غريب شوية، لأنه السؤال الأول اللي أنا داير أسأله منو collected الداتا، وهل في الاوديت الاول ما الاوديت الثاني هل الناس اللي كنتوا بتعملوا كولكشن للديتا حقتهم هل كانوا عارفين انكم بتعملوا كولكشن للديتا حقت الهاند واشنج ولا ما كانوا عارفينه؟
No, of course not. In the first cycle أصلا ما كان في زول عارف إنه نجمع في داتا، وحتى كان second cycle برضه كده. التشيك ليست اللي كان عملناها ما عملنا observing، يعني ما أقول لك إنه شلنا التشيك ليست وديناها للدكتور، لا. التشيك ليست كانت عندنا إحنا ال observers، and we just see the doctors and تشيك يعني.
و كويس. طيب لكن انت قلت انا ما عندنا population، لكن لا انت عندي population دي للدكاتره اللي انت عملت لهم
أيوة
observation وعملتي collection للديت حقتهم، فبعدين لما تقدم الاوديت يذكر ان population حقتك يا هم ذاتهم الدكاتره اللي انت
بالضبط.
شفتين.
أيوة
بعد ذاك حاولي في البرزنتيشن قسمها انه الفيرست سايكل عملناه كده، بعد ذاك الانترفنشن اللي عملناه. يعني الانترفنشن يعني اضطرينا نقلع وقلع عشان نعرف هو كان عباره عشان make it very clear انه نحن عملنا كده. بعد ذاك اتكلمنا مع الكواليتي امبروفمنت، عملنا تريز في الهاند هايجين، عملنا هاند هايجين ستيشنز، عملنا بوسترز، عملنا educations. وبعد ذاك جينا وي ريبيتد الاوديت. وحتى يعني انت الشغل اللي عملتيه بتاع التراكنج بيتكلم الناس دي مع ناس الانفكشن كنترول ان جنرال، يعني you were doing that job يعني which is great يعني. لكن يعني مثلا عندنا هنا في
واستخدمته يعني اتكلمنا مع الكواليتي امبروفمنت اوفيس اللي هو
ايوه
ماسكين الكلينيكال اوديتس، حتى برضه اتكلمنا عن الانفكشن كنترول،
ايوه ايوه
وهم الاثنين المفترض نعمل لهم برزنتيشن تاني.
ايوه ممتاز. الحاجه الاخيره، هل لاحظتوا انه في مثلا ريدكشن السيرجيكال سايت انفكشن ريت او الكروس بيشنتس كونتامينيشنز؟ يعني هل كان في كيسز مثلا كان عندك 5 عيانين في العنبر عاملين لهم لابروتوميز في لحظه ما قبل قبل الاوديت، كان كله 10 عيانين بيكون في 6 منهم عندهم ووند انفكشن، هل بعد الاوديت حصل امبروفمنت ولا لا؟ لانه ده الايم بتاعك صح؟ ده الايم بتاعك في
لا
النهايه انه
ما لاحظنا الحاجة دي. ركزنا بس على
مم.
المومنتس والاتريمز بتاع.
كويس
ايوه
كويس فيري جود. لكن دي ان جنرال، ما عشان كده الناس بتعمل الهاند هايجين في المستشفى صح؟ بالذات عندنا في السيرجيكال ديبارتمنت عشان نقلل
ايوه
السيرجيكال سايت انفكشن وعشان نقلل الكروس كونتامينيشن بين العيان. لكن ممتاز ويل دون. ايوه اخر حاجه
ثانك يو.
سوري، خدت لك جرافس عليك الله في البرزنتيشنز، خدت لك جرافس ولا فيجرز في البرزنتيشنز comparing يعني مثلا كباي تشارت ولا بار تشارت، تعمل لك كومباريزون اظرف مما يكون الكلام كله في السلايد مكتوب
ايوه
وفيه فيه النمبرز، عرفتي دائما بتكون ما حلوه في البرزنتيشنز، فتراي تو ميك ات انها مثلا
حاضر
بار تشارت ولا باي تشارت. المهم فيري ايزي يعني، ما حاجه سيمبل بتكون مور appealing يعني. تمام
حاضر ان شاء الله.
ممتاز. Thank you.
جزاك الله خير.
الله يخليك.
Thank you very much, Dr. Omniat and Dr. Hazem, for this great discussion. If anyone have any last remarks or any questions for the audit team before we finish? Okay. If so, thank you everyone. Thank you everyone for attending our journal club and audit presentation. We've reached the end of what was a truly engaging and thought-provoking session. I want to extend my sincere gratitude for everyone who presented today. Dr. Tessir, Dr. Baha, Dr. Rimaz, Dr. Omniat, and thank you very much for also those who participated in the discussion, Dr. Hazm and Dr. Shima. Thank you very much for sharing your expertise and hard work with us. I think this is it for tonight. We will share a feedback form. Please fill the feedback form in our WhatsApp group. Thank you, everyone. Dr. Muhammad Adam have a final remark. If you can go ahead, Dr.
السلام عليكم. شكرا يا نزار، شكرا Research Department. شكرا يعني our guest speakers Mr. حازم، شكرا جزيلا. ما تكون متذكرني لكن تلاقينا في أمستردام أو أستراليا ياسين لو متذكر. شكرا خالص على الكومنتس very like thoughtful and insightful. وشكرا دكتور شيماء، يعني السيشنز دي بقت تخلينا الاقيك اتليست يا دكتور شيماء. فشكرا يا شباب، وشكرا التيم بتاع الكلينيكال اوديت. This is really great اننا نشوف الاوتكمز بتاع شغلكم، وبليز كيب ات اب، ونتلاقى ان شاء الله في السيشنات الجايه. شكرا جزيلا.
Thank you, everyone.